Dear colleagues, this is a very interesting case. This patient sustained trauma in his right eye. He came to me with dilated pupil with sphincter tear, and I suspected tear of zonular fibres. He had almost mature cataract. He also had hyphema which was lavaged elsewhere. I have taken up this case for surgery. Capsulorhexis is being done gently. When I punctured the anterior capsule, the whole lens moved and I could see that the zonule is really weak. And I have already suspected that somewhere there may be zonular dehiscence. So capsulorhexis has been done and now hydrodissection is done, but I do not rotate the nucleus. Before rotating the nucleus, I want to place the C-tear, a capsular tension ring. Here it goes. The C-tear is being introduced through the main incision. The leading end goes, it is being introduced into the capsular bag from 7 o'clock. Yes, it has gone into the capsular bag. It is now at the equator and it is rotating, and now I have come to the trailing end. Now I have to place this trailing end into the capsular bag. Here it is. I take a Sinskey hook, go through the side port, and I hold this trailing end, but it doesn't go. It has slipped. So I hold it again with the dialer and I place it in the capsular bag. That's it. I have supported the bag. Now I inject some of viscoelastic substance. Now I try to rotate the nucleus. It doesn't rotate. Although I did hydrodissection, it's not rotating. So I have to do some more hydrodissection. Here it is. I take a 27 gauge cannula. BSS is being used for hydrodissection, and now I try to rotate the nucleus with two instruments, one chopper in the left hand and dialer in the right hand, and it rotates now freely. Now I inject viscoelastic substance and now I go into the eye with the phaco handpiece. Here it goes. I'm going to use Oatly Cataract's easy phaco machine, and I want to do direct chop in this case. Here it is. The tip is buried into the nucleus, and this is the chop. Now in this way I divide the nucleus into several fragments, and each fragment is emulsified and removed, and this is the last fragment. When I emulsify the last fragment, in such cases I come to phaco on mode, where the vacuum is very low, about 50 or 70, so that I do not catch the posterior capsule. Now before I come out, I ask my assistant to give me viscoelastic substance, and I take HPMC. I hold the base of the cannula. This is a 23 gauge cannula, and as my assistant injects, viscoelastic substance and the capsular bag is supported, I come out. And now I use bimanual irrigation aspiration for removing the cortical matter. I also use a direct Simcoe cannula for removal of this cortical matter. Now once this is nicely cleaned, here it is. This is a viscoat. I want to protect the I want to protect the corneal endothelium, and this is HPMC. Now I inject a hydrophilic acrylic intraocular lens into the capsular bag. Here it is. Now the mistake here I did is I dialed the lens. If I keep the lens like this, probably I dialed the lens and I changed the position of the haptics, and probably at that time the weak zonule just in front of the main incision gave way, and here it is. As I try to remove the viscoelastic substance, the vitreous is getting hydrated, and I can see that the gap just in front of the main incision is increasing. That's it. And now I am in problem, and vitreous has already come out through the main incision. So I try to do vitrectomy. I try to shave this vitreous, but I can't. More vitreous comes. So what I do is I go into the anterior vitreous. I keep the cutting port towards the optic nerve so that I do not catch the posterior capsule, and I do a nice anterior vitrectomy. When I do this, whatever vitreous was there just in front of the main incision, whatever vitreous strands were there, they go back, and this I am in command now again. Now I inject air, hydrate the side ports. Now I check whether all the vitreous strands are behind the posterior capsule or not. Now as I try to remove this triamcinolone acetate through the side port at 8 o'clock, I find that some more strands are still there in the anterior chamber, and so I go again with the cutter. Irrigation is at 8 o'clock, the cutter is at 2 o'clock, and I do a nice anterior vitrectomy of the strands of vitreous just in front of the main incision. And that's it. When it is done, I am about to conclude the case. This is an edited video because the surgery was long, and here it is. I form the anterior chamber with a Simcoe cannula and conclude the case. Hope this video will be helpful in your practice. Thank you very much for watching this video.